So I am going to go ahead and introduce our esteemed speakers. Dr. Kurian is a professor of medicine and of epidemiology and population health at Stanford University. And remember that photo from the first Joining Forces conference? Allison was there too. She is Associate Chief of the Division of Oncology, Director of the Stanford Women's Clinical Cancer Genetics Program, and co-leader of the Stanford Cancer Institute Population Sciences Program. She's also been a very long-standing member of our Scientific Advisory Board, our Board of Directors, and I don't think that Allison has ever said no to any request that we've ever asked of her, so we really appreciate it. And I'm going to introduce our second speaker, and then you guys can go ahead and get the presentation started. Dr. Bever is an assistant professor at Johns Hopkins University in Baltimore, Maryland. She's a medical oncologist who cares for patients with gastrointestinal cancers, and her research focuses on the development of clinical trials to identify new, more effective treatments of these cancers, particularly evaluating novel immunotherapy combinations. So thank you so much. I'm going to invite up Dr. Kurian. The clicker's
perfect. Keeping things on the ground. Anyway, thank you for that very kind introduction, Sue, and you're absolutely right. I will come when you call me, for sure. And it's a privilege to be here, and this organization means a very great deal, I think, to all of us, and just want to celebrate the 25 years. Very big deal, and congratulations. So, really exciting. And now we will move into the subject for today, which is targeted therapy. And I will be starting mostly on therapy for breast and ovarian and some other cancers, and then my colleague, Dr. Bever, will be speaking more about immunotherapy to give you a sense of where we're going. So my disclosures are here. And what is targeted therapy? This is treatment that is designed to home in to a specific cancer cell receptor or pathway. And the goal of all this is to improve efficacy and accuracy for hitting the cancer cell and not hitting everything else. So ideally, both more effective and less toxic. And whenever possible in oncology, we're trying to replace chemotherapy, cytotoxic chemotherapy that just sort of kills everything that grows fast, with targeted therapy if we can. And I think the key point here, which you'll see in the talk, is that targeted therapy stands on the shoulders of scientific progress in basic science, in molecular and cell biology, and that investment is what keeps all of this going. It's key that we understand the cellular pathways to exploit to be able to design targeted therapy. And some key kinds of therapy and molecules that you'll see referred to are monoclonal antibodies. We think of these as kind of a lock and key fit of basically binding to a specific protein or receptor. And our body makes antibodies against infectious agents, but these then get engineered in the laboratory to treat specific cancer targets. That's one type of therapy you'll see. The other type is what we often call small molecule inhibitors, and these sometimes are what we call tyrosine kinases, which act as an on or off switch for certain processes in the cell. So that's a summary, but just an idea of kind of how to think about this. And I want to provide a few illustrations and explain them, which may be useful for some of the things you see in this talk. The one on the left is one that I borrowed with permission. Juanita said I could from the Force website. This is targeted therapy, and I thought a really nice illustration of the point here. And what you see in this picture, on the left of the picture, is a normal cell, and it just shows sort of a cartoon example of receptors. When I talk to patients and when I think about receptors, I like to describe them as kind of like a catcher's mitt, like in baseball. This, again, is a simplification, but it helps me think about it. So you can sort of imagine it sitting there and getting triggered by something that comes along. And so in a normal cell, there would be the right number of whatever that receptor was. The idea being that in a cancer cell, as you can see here on the right, we might see many more of these or abnormal versions of these. And thus the idea would be that the cancer cell would be more susceptible to hitting that target and sparing a normal cell. So the other thing I wanted to tell you about, just because you'll see it during the talk, is this survival analysis here. And this is basically the way we determine if something is working in a clinical trial when you're looking at the data. And so the idea here is that on the vertical axis or the y-axis, it is the percent of people or whatever is being studied. It could be mice, it could be bacterial colonies, but the percent of whatever it is that is still alive or in the state that you want to be in, so without cancer having grown or things like that. Then the x-axis, the horizontal axis, is time. So here, if we imagine years, you can see that there are two groups, group 1 and group 2. And in a curve like this, you would always want to be on the one closer to the top, because those people are having longer survival. And just as an example here, group 1 reaches 50% of whatever is still alive at 1.5 years, right? But for I'm sorry, that was group 2, I apologize, group 2 down there. Group 1, it takes more like 3.5 years. So you just get a sense of kind of how this works. And sometimes people will ask, why do these curves have these step-offs, right? And usually that's because these are times when people get measured. So maybe here you have a measurement and you realize that some people are no longer on the surviving curve, so you get a step down. So just so you see how these look if you ever see clinical trial results. So let's begin by talking about the important cellular pathways here. DNA damage repair is going to be a key theme that you will hear, and that is because BRCA1 and BRCA2 have a normal function to act to repair damaged DNA. And so as we think about cells, cancer cells or otherwise, proliferating and growing, basically before they do that, they need to check that their DNA, the blueprint for growth, is normal before going on. That is a normal process. And when errors happen in DNA, I like to think of it as a molecular spell checker system, that basically there are various ways to fix the damage before going on. And this is an image I like from an older paper, but that shows you basically all the bad things that can happen to DNA. So you can have a single strand break, a double strand break, et cetera, and the different systems in our cells for fixing that. And so a few things that are going to come up, if you have a single strand break, you go through something called the base excision repair pathway, and that is helped by PARP1, which is a protein that acts there for DNA repair. BRCA1 and BRCA2 come in here for homologous recombination of double-strand breaks. And again, it's a lot of jargon, but just the point being that they have kind of parallel functions, and you can rely on each of them to do the work of DNA repair. And there are a few others that are important here. You may hear Dr. Bever talk about some of these genes, MSH2 and MLH1, which are genes that cause Lynch syndrome when they're not functioning. But the point being DNA repair is key. And so knowing this, again, there's been this goal to try to exploit this reliance of a cancer cell on these pathways for DNA repair and think about ways we can interfere to kill off the cancer cells but keep normal cells functioning and do better for patients. And just in general, cells tend to be more sensitive to treatments that block that PARP pathway if they're unstable, if they've sort of acquired other mutations, if they're growing quickly, and that kind of gives you a sense of what typically gets targeted. So we're going to talk a lot about PARP inhibitors because they're this very exciting BRCA-targeted therapy. And just to discuss a little bit about their mechanism, they work by something we call synthetic lethality. And I like the cartoon on the left for describing that. And so what it basically means is that for a cancer cell, it needs to be able to repair its DNA well enough to replicate. It may have a lot of errors, because cancer cells do, but it needs to basically make the car run to move forward. And so there are two pathways that it can use to do this. One is BRCA1 or 2, and think of that as kind of a single pathway. If either BRCA1 or BRCA2 aren't working, that pathway would be out, okay? And then there's this other one, PARP1, and it can sort of rely on either of those. So this is just showing us at the top, if both protein A, let's say PARP1, and B, BRCA1 and 2 are intact, the cell survives. And the next two down, if you knock out either of them but leave the other one, the cell survives. But if you knock out both, that cancer cell cannot repair its DNA well enough to move forward and will die. So that's the idea of a PARP inhibitor. BRCA1 or 2 is down, you block the PARP inhibitor and the cell dies. But in normal cells that still have at least one copy of BRCA1 and 2, they don't get killed. And that's the idea behind it. And so this is just a figure to show that there are probably lots of other ways to get to synthetic lethality. I won't go through it all, but potentially combining drugs from screens and things like that. So this was an important principle of drug design that really came to the fore in thinking about BRCA1 and BRCA2. And this has been a long time coming, and I think an exciting thing to think about. So it's really been 5 decades, almost 6, that we have been thinking about PARP inhibitors. And first of all, in 1963, the molecule poly-ADP ribose was discovered. In 1977, PARP1 protein purified. In 1980, actually, in the laboratory, an early PARP inhibitor of that function called benzamide was discovered. And then in 1987, with the genetic revolution, we saw the gene of PARP1 be cloned. And it really wasn't until the mid-2000s here that there began to be this idea that maybe if you blocked PARP, you could do something useful in cancer cells that also lacked BRCA1 and BRCA2. About 5 years after that, we saw some first proof of concept trials of beginning to target these to see a benefit. And then, as of 2014, we see this amazing cascade of multiple different studies showing benefit in clinical trials for first any type of cancer with a BRCA mutation, and then all of the cancers that are typically associated with BRCA1 and 2 that we think of kind of as the canonical or typical ones: breast, ovarian, pancreatic, and prostate cancer. Initially with metastatic or advanced disease, and the one I'll talk about that really was the most exciting in 2021 was in the early stage disease. So cancer of stage 2 or 3 that we think of as still quite curable, giving a PARP inhibitor after that and showing a really big benefit. So the field has come a long way. And just to talk a little bit about what these PARP inhibitors are, on the left you can see structures, and I promise there will be no quizzes on benzene rings or anything nerdy like that. It's been a long time for me as well from chemistry. But just to give you a sense, there are 5 PARP inhibitors around and studied in clinical trials. They're listed here according to their potency of PARP trapping in terms of their binding. It was thought that this would be correlated with effectiveness. It probably isn't. I just like this figure in terms of showing what they look like. And in terms of these 5 PARP inhibitors, you can see the status in terms of their approval for use in the clinic by the Food and Drug Administration here. So it mostly is a question of who came first in terms of manufacturing. And you see that olaparib, whose other name is Lynparza, is the one that first got approved for ovarian cancer, then breast, pancreatic, and prostate cancer. Rucaparib, which I believe is Rubraca, and then niraparib, which I think is Zejula. I always have to remember all these names. Early in the morning for me is, at any rate, approved both of those for ovarian and prostate cancer. And then talazoparib, or Talzenna, is approved for breast and for prostate cancer. Veliparib, to my knowledge, is not currently FDA approved for anything. There have been trials in breast cancer, and it has orphan drug status for non-small cell lung cancer, which is sort of ways to get it that are not FDA approved, but that one is sort of a little behind the others. So getting into the early basic science, this is a bit of what I described before, but just showing you as a figure. Again, cancer cell has to repair damaged DNA. If it has PARP, it does fine, it can use that. If it doesn't have PARP and it doesn't have BRCA1 or BRCA2, you have a problem and the cell can't replicate. And when people looked at cell colonies to measure whether indeed these cancer cells could grow, you can see that if BRCA1 or BRCA2 were fine, there was no mutation, and you gave the cell a PARP inhibitor, you got a lot of cell colonies, whereas if you looked at cells that lacked BRCA2 or BRCA1, you didn't get so many. So just again, the first proof of principle in the laboratory that made scientists think this was a good idea to try. And this is one of the first proof of concept clinical trials. This was basically to show that olaparib could hit the target. that there was evidence when you did assays in the laboratory of blocking of the PARP pathway in people. And as sort of a bonus, they also showed that they'd begun to use it in some patients with advanced BRCA-associated cancers. And basically, the big deal was seeing things shrink. So these are CT scans, which always look a little weird. The way to think about them is that the patient is lying on a table, on a CT scan table. These are cuts, sort of basically horizontal cuts through the body by imaging, and imagine the feet sticking out at you, basically. I'm not a radiologist, but this is how I think about that. So that's sort of the way this would look. And just to orient you, that is the vertebral body, the spine, and here are the ribs in the back, and this is the front of the abdominal wall. So in this patient in this study, this person had a pretty big tumor deposit right in the abdominal wall here of about 5 centimeters, 53 millimeters. After 4 months on a PARP inhibitor, that shrunk down to 1.8 centimeters, 18 millimeters. Here's another one who had a 23 millimeter, 2 centimeter tumor deposit that was gone. So again, just beginning to see some of the early successes here with targeted therapy. And then we get into this era of a lot of big trials. I promised you we would have survival curves galore, and here we go. But just so you know what you're looking at, these were some of the trials that really showed that PARP inhibitors work for ovarian cancer. And I won't belabor all of this, but the point that I want to make is with survival curves like this, the things we like to see is a big difference between the curves. So the more error you can see between the two curves, the better the benefit is, right? These people are getting more benefit from the line on the top. And in all of these trials, the line on the top is the PARP inhibitor, okay? So very clear that there's a benefit there for patients with BRCA 1 and 2 mutations. And it was kind of interesting. With ovarian cancer, there was a trial called the NOVA trial with this drug niraparib. And what you see here was giving a PARP inhibitor to people with BRCA 1 and 2 mutations who had ovarian cancer. There's a big gap, right? So it's working really well for those people. They also tried it in people who didn't have BRCA mutations, and you see it worked, but not as well. So it's kind of interesting that clearly there was a signal that it was better for people with gene mutations. And then rucaparib, there, another drug. These were initially in quite advanced ovarian cancer, which is often where trials start because there's the greatest need. But then as they went forward, there was also evidence of benefit in earlier stage ovarian cancer where people had just been treated with chemotherapy, benefit on the left from the olaparib or Lynparza, on the right from veliparib, which again is this not yet approved PARP inhibitor with chemotherapy. And this established these drugs as the standard of care after chemotherapy for people with ovarian cancer. The next big development here was breast cancer. And so in 2017 and 18, there were 2 big trials that were quite similar. The one on the left there was called Olympiad and used olaparib. They always had these like cute names for clinical trials, right? And then the one on the right was called Embraca and used talazoparib. But the point here is that the shape of these curves is very similar. The amount of daylight between the curves is very similar. And what you'll actually see, and is true, is that it looks like the gap here is not as big as it was for ovarian cancer. And that's correct. These drugs are effective for metastatic breast cancer, but not to the same extent as ovarian cancer. And that probably has to do with ovarian cancer biology. So these drugs can prevent disease progression for a while with metastatic breast cancer, and they can provide better quality of life, but they do not improve overall survival, which is kind of the gold standard in thinking about a drug for cancer. So it gives you a sense, though, of what was found. And then the big exciting trial, as I mentioned, was Olympia. So this was early breast cancer. Here you see another one of these survival curves, and what you see here is that the bottom line, the placebo or control arm, is much higher because people do better with early stage breast cancer. And it doesn't look like maybe there's so much daylight just because this curve is higher, but I'll tell you that for early stage breast cancer, this is actually quite a big benefit, this gap, in terms of what people got. So in this trial, people had surgery, they had chemotherapy generally, and then they were randomized to either nothing, or standard of care, maybe hormonal therapy if it was indicated, versus the PARP inhibitor for a year. And what was found was that in every subgroup studied, people really benefited from the PARP inhibitor. I won't get too much into this, but this is called a tornado plot, is one way to call it. It's basically, or a forest plot. It's a subset analysis. And basically it says whoever you were, if you had BRCA1 versus BRCA2, if you had prior chemo or not, for all those people, they were on the left side of the line, which means that the medication, the olaparib, worked better. So it was very consistent. And there was a clear overall survival benefit, and this really is the first example of targeting an inherited gene mutation and improving survival and cure rate in early stage breast cancer. So a huge advance, not just for people with genetic mutations, but for science in general. Big deal. So just a few more things to show here. These are PARP inhibitors with pancreatic and prostate cancer, more advanced cancers. And again, just a point, you see the shape of the pancreatic cancer curve, right? Unfortunately, fall off really fast because this is a bad disease in terms of poor survival, but still a gap. Prostate cancer, fortunately not quite as steep a curve. Again, still a gap between the two. And I'll just comment that there have been a few studies of PARP inhibitors in combination because people are starting to say, what if we add PARP inhibitors to other things? I won't talk a lot about immune therapy because I know Dr. Bever will, but I'll just say immune therapy, turning on the immune system to try to fight cancer. There have been a few trials now, Topazio and Mediola, that look at that. You can see with this survival plot here that people got quite a bit of benefit when you gave a PARP inhibitor with the immune drug here. And in Mediola, this is a different kind of plot. It's usually called a swimmer's plot, and you see that people went on for a long time with the drug and did well. And then again, there's been this trial with veliparib and chemotherapy called the Brocade 3 trial. I think Force did some recruitment for that, as I recall, and that also was beneficial. So a lot about PARP inhibitors. I'll just say that unfortunately nothing works forever, or most of the time nothing works forever in oncology. And cancer cells are cleverer than we would like and often can develop really quite ingenious methods of resistance that are alarming. One of them is remarkable. It actually can be a reversion mutation, meaning that the BRCA mutation actually can get sort of rejiggered in the cell so that it's not deficient anymore. And it's a way of rescuing the cancer cell from PARP inhibition, which is kind of diabolical and you wish it wouldn't. But that's how it works. Cancer cells are under evolutionary pressure, and so things develop. The other is what we call a drug efflux pump. Basically, the cell makes this kind of channel through the cell membrane to pump drug out. So again, it's sort of alarming, right? But it's able to do those things. So it's all about keeping one step ahead. And I'll just say that in terms of what's next after PARP inhibitors, this is a busy slide, but it's just to show you there are many different biological pathways of things like cell cycle and cell division, DNA repair, where people are taking these apart and trying to find targets to intervene. Some promising ones right now are ATR and CHEK1/2 that work in DNA repair, and there are studies of inhibitors ongoing now. And I'll close by just talking about two other sets of targeted therapy quickly that people may come across, particularly breast cancer. I'm a breast cancer doctor, so I'll use examples from that. But probably the most famous is targeting HER2. And that is what I think of as kind of an aggressiveness factor or a receptor that is often amplified in certain kinds of breast cancer, HER2 positive breast cancer. So this was really one of the very first targeted therapies using a monoclonal antibody to specifically target HER2. And as an example of that, this is an example of another drug I'll tell you about, but it's sort of this Y shape where basically it would bind to HER2 and help kill the cancer. And there was this very exciting study in 2005 that showed that in women with early breast cancer who got the drug trastuzumab, also known as Herceptin, versus not, a huge gap, and people did very well. Now, people have found a way to kind of soup this up, right, to do even more. And what they've done is to say, well, what if we attach chemotherapy molecules to this antibody and kind of make it like a smart bomb? People have heard of that as the payload of the antibody, and they call this an antibody-drug conjugate. It's called trastuzumab deruxtecan, just because, why should we be able to pronounce it early or easily, right? It's always tough. But trastuzumab deruxtecan, also known as Enhertu, and that's just an example of really taking it to the next level with molecular biology and these antibodies. So some other targeted therapies you'll hear about in breast cancer are for cell signaling. The example on the left basically shows a signaling cascade in the cell. For example, a growth factor might turn on the cancer cell to grow, and there's this whole molecular pathway. Molecules like PI3K, PTEN, AKT, new drugs target those, capivasertib and alpelisib. Another one is selective estrogen response modifiers or estrogen receptor degraders like elacestrant that do various things in the cell to get rid of the estrogen response. So I'm going to stop now and just say that the main points are that targeted therapies save lives from cancer and reduce side effects. PARP inhibitors are really exciting because they are the first therapy targeted to an inherited mutation. They improve early-stage disease survival. Unfortunately, they still don't cure metastatic disease, and that's a frontier that needs to be addressed. And many other targeted agents are in clinical use and development now. Thanks so much.
Okay, thank you, Allison, for starting us off. That was a great overview, and it's going to help me a lot in my discussion. And thank you, Sue, for the invitation to be here today. Again, my name is Katherine Bever. I'm a medical oncologist at Johns Hopkins, and my clinical and research interest is in treating gastrointestinal cancers with immunotherapy in particular. So I'm very happy to be here to give this talk today. These are my disclosures. So we'll start off with what is immunotherapy. We just heard a lot about targeted therapy, and Allison alluded to this, but immunotherapy are medications that are trying to work with the patient's own immune system to fight the cancer. So that's as opposed to chemo or targeted therapy, which is actually targeting the cancer cells themselves. These drugs are acting on your immune cells. And the premise here is that cancer should be able to be recognized by your immune system as something abnormal and eliminated from the body. But we know that oftentimes that doesn't happen. That's why cancer is, and we know that that's because it has strategies to evade immune detection. One of these strategies is the so-called immune checkpoints. These are proteins that are expressed on the cell surface of the tumor that can bind to immune cells receptors, those baseball gloves that Allison described, and they can send a signal to the immune system saying, I'm okay, don't worry about me. So this is a very important mechanism that we have in our body to prevent autoimmune problems, so the immune system attacking normal tissue. It also can downregulate or dampen an overexuberant immune response. If you have an infection or something, sometimes your immune response can be problematic. But we know that cancer can hijack this as well. And some examples of these immune checkpoints that I'll mention in this talk are PD-1 and its ligand, PD-L1, CTLA-4, and LAG-3. And this is just a graphic showing what I just described. This is the example of PD-1 and its ligand. So you can see that PD-L1 is expressed on the surface of the tumor cell, and it can bind to that PD-1 receptor on the immune cell and send that signal to shut down the immune response. And so the idea with these immunotherapy drugs is that we're just blocking that interaction between the receptor and its ligand, and that allows the T cell, which is the soldier of the immune system, to wake up and fight the cancer cells. So immunotherapy has some potential advantages over, for example, chemotherapy and targeted therapy. One is, a big one I would say, is the potential durability of response. So these drugs don't work in everyone, but sometimes when they do, it can be a very durable, long-lasting benefit. And it's the same idea with how our body can develop a lifelong immunity to a childhood virus or something like that. Once the immune system is activated against the cancer, that's something that can last a very long time potentially. Tolerability I also put as a potential advantage. A lot of people on immunotherapy don't really feel that different when they get the treatment. So that's as opposed to chemotherapy or targeted therapy where we kind of know that there's some predictable effects on the body. But on the other hand of this, in the column of disadvantages, there are risks of immunotherapy. The main one is that we can activate the immune system against healthy parts of the body again, so we can see these autoimmune problems develop in patients on immunotherapy. And that can be very hard to predict. It doesn't happen in everyone. We don't really have a way to know if it's going to happen in you or how it might affect your body. It can be really mild things like skin rashes or a thyroid issue, or on the other end of the spectrum, really severe or even life-threatening if the immune system affects a vital organ like your heart or lungs, for example. So the risks are there. Financial costs I put as well. These drugs are incredibly expensive right now, and that's certainly something that we always should be considering. And then I put low response rates, and this varies widely from one type of cancer to another, as we'll discuss, but I think it does have to be a factor in cancers where the response rate is low. The likelihood that we're going to see shrinkage of the cancer is lower, obviously, in that patient. And so in aggressive cancers in particular, sometimes immunotherapy isn't going to be the best choice. So I mentioned this, that immunotherapy works particularly well in certain cancers. These data are from a very early study of a drug called nivolumab, which is a PD-1 inhibitor, and this was the phase 1 trial, so kind of the first in human trial of this drug in patients with advanced cancers. And what they did, and we often do when we're starting out looking at how a drug works, is they tried it in multiple different cancer types. And what we quickly recognized is that these drugs work pretty well in certain cancers, which are shown here. This plot on the left here, there we go, is a spider plot. Allison showed you a lot of survival curves. This is different. This is showing the measurements of patients' tumors over time. So each patient on this plot is a line, and what we like to see is that the lines are going down. That means the cancers are getting smaller, the patients are responding. And so in this plot of the melanoma patients on this trial, you can see lots of lines going down. So the drug worked very well in melanoma. Similarly, they saw good responses in lung cancer and kidney cancer. And kind of a unifying feature of these more immune responsive cancers is that they have a lot of mutations. So for the example of melanoma, it's associated with UV exposure, which causes mutations, and that's why the cancer develops, but also makes it a very high mutational burden cancer. Similarly with lung cancer, the association with tobacco exposure. So these are cancer cells that look very abnormal to the immune system at the get-go, and once we apply these immunotherapy drugs, it's much easier for the immune system to recognize them as something foreign and go after them. So I'm here to talk about the relationship of immunotherapy to hereditary cancers, and I think the main way that this applies is in the mismatch repair deficient cancers. These are cancers that can develop in patients with Lynch syndrome, or they can also occur sporadically, so we see them in patients without heritable predispositions as well. But as Allison described, this is one of the pathways that cells use to repair errors in their DNA. So when cells are dividing and replicating, they have to make copies of their DNA for the next cell. And it's normal that there are errors that happen in this process, and so the cells need lots of different ways to fix those errors, depending on the type of error that happens. And mismatch repair is one of the ways that it fixes errors, but we know that sometimes this pathway is broken in cancer cells. And in the case of Lynch syndrome, people are born with a mutation in one of those mismatch repair proteins. So what happens when the cancer cell can't repair these mismatch errors normally? These cells develop high levels of microsatellite instability, so we often refer to them as MSI high as well. But the end result is that just like the case of a melanoma or lung cancer, these are cancers that have lots of mutations. They express all these abnormal proteins that make it very visible to the immune system as something abnormal. So my colleagues at Johns Hopkins, Young Lee and Luis Diaz, who's now moved on to Memorial Sloan Kettering, had this good idea to look at immunotherapy in mismatch repair deficient cancers. This was a phase 2 trial that enrolled patients with any type of solid tumor cancer that had this mismatch repair deficiency. And these were patients with advanced metastatic disease who had already received standard treatment with chemotherapy and unfortunately progressed, as we know happens. And they were treated with this drug pembrolizumab, which is another PD-1 inhibitor. So on the left here, you can see the pie chart, which is just showing you all the different types of cancers that they treated. And this plot on the bottom here is what we call a waterfall plot, which is another way to show responses to the trial treatment. And in this case, each bar is one patient. The color of the bar corresponds to the type of cancer they had in the pie chart. And then the height of the bar tells you the best change in the size of their cancer while they were on the study treatment. And so what we like to see and what we're seeing here again is that most of the bars are going down. That means patients' tumors are getting smaller on treatment. And very significantly, there's this group of patients who had 100% reductions of their tumor sizes, meaning the cancer went away on immunotherapy. Allison showed you one of these swimmers plots before. Basically, this is, again, each patient is a bar, and we're following them over time on the x-axis. And so it's kind of showing what happened to patients over time while they were on the trial. And you can see the blue dots here. There are a few patients who unfortunately succumbed to their disease, but a large number of patients who are continuing to survive on study, which again is pretty significant for this patient population of advanced cancer that had failed standard treatment, basically. And you can also see these orange triangles are where treatment stopped, and so a lot of patients made it to the 2 years or maybe stopped early for whatever reason, but continue to survive beyond that and do well. So this was a pretty exciting trial and an exciting time for oncology when we saw these results, and the FDA granted historic tissue agnostic approval for pembrolizumab on the basis of these results. This was, may not sound very exciting, but it was a big deal because it's the kind of the first time that the FDA recognized that there are treatments for cancer that don't depend on where the cancer started. So, you know, historically, the way we determined a cancer treatment was if you got breast cancer, you got this type of chemo drug. If you had colon cancer, this type of drug. But this is saying that that doesn't necessarily need to be the case, that there are biomarkers that we can apply to patients regardless of their tumor type. So we also have some experience with using combination immunotherapy in these mismatch repair deficient cancers. This is a trial, Checkmate 142, in metastatic colon cancer that has this mismatch repair deficiency. And they enrolled patients to receive either single agent immunotherapy, that nivolumab drug I mentioned earlier, or nivolumab combined with ipilimumab. And what they saw, and this is consistent with what we've seen in other settings in melanoma and lung cancer as well, we do see more patients will respond when we give the combination treatment. So you can see 65% of patients responding versus 39%. More patients alive and free from progression at 5 years. But the flip side of that is that we know now from a lot of experience with ipilimumab is it does add significant toxicity, more risk of side effects, like I mentioned, these autoimmune problems. And so the TRAE stands for treatment-related adverse event, which is the side effects I'm talking about. You can see any treatment-related adverse event doesn't look that much worse, but when we look at serious treatment-related adverse events or adverse events leading to treatment discontinuation, which are usually pretty significant, those are almost double in the patients who got the combination. So this has been kind of a new challenge for the field, I think, or where the field is headed is how do we determine, which patients need this combination, need to take that risk of more side effects, who's not going to respond to the single agent, because we know so many patients do. So to that end, we have a clinical trial at Johns Hopkins, which is currently enrolling. This is for patients with mismatch repair deficient or MSI high cancers who have already received PD-1 or PD-L1 inhibitors and had progression of their cancer. And we're treating them with this combination of a PD-1 and a LAG-3 inhibitor. I mentioned LAG-3 before, which is another immune checkpoint. And so the question is whether we can kind of restore responses in these patients with PD-1 resistant cancer. We hope to also be able to look at these patient samples and try to understand why they were resistant to PD-1 in the first place, which I think, again, is an important open question in our field. This data is still maturing. We're still enrolling patients, but I just wanted to share an example of one patient who's done particularly well. This is a gentleman with metastatic colon cancer who had already received PD-1 inhibitor as well as the PD-1 plus CTLA-4 combination and had progression of his cancer prior to enrolling on our study. And he had a lot of these subcutaneous tumors, as you can see in the arrow here. And those really dramatically melted away on the treatment. This is again showing the change in the size of his tumors over time. And you can see there's kind of this gradual decline. He's been on study over 5 years now and continues to do well with kind of this continued incremental benefit. Another way that we're trying to improve responses with hopefully less toxicity in these patients is through the use of cancer vaccines. So cancer vaccines are kind of based on the same principle as what we're familiar with for infectious diseases, where we're giving, presenting an antigen to the immune system in the presence of something to stimulate the immune response. But in this case, it's being used for patients that already have cancer and trying to help the immune system to recognize things in the cancer that it can kind of focus its immune attack on. So this particular example is a drug called NOUS 209. This is what we refer to as an off-the-shelf vaccine, which is as opposed to a personalized vaccine where the vaccine is made based on the patient's own cancer cells. This one is just based on some commonly shared peptides among patients who have this type of mismatch repair deficient or MSI high cancer. And so this is a phase 1 study where they're combining the vaccine with pembrolizumab, that PD-1 inhibitor drug. And just showing you, this is the preliminary results which were presented a couple of years ago. This study is still ongoing, so we haven't seen the final results, but just showing again, this is a spider plot where each patient is a line, and you can see that a lot of the lines are going down or staying stable, meaning most patients seem to have some clinical benefit. And not shown here is that so far what we've seen is the toxicity of the vaccine doesn't seem to add much to what we already know to expect with PD-1 inhibitor. So what about for early stage disease? Everything I've talked about thus far is in patients with metastatic disease. Early stage disease, again, is the setting where we believe we can cure patients, and historically that was just with surgery. So if somebody had a cancer that was localized, the strategy was just to get it out and hope that that cured them, sometimes add on chemotherapy or other treatments to improve the chances of cure. But the question now is whether immunotherapy has a role in that setting as well. This is a study that was presented a couple of years ago. We actually have some updated data from it now, but it made quite a splash even 2 years ago. This was a phase 2 study in patients with early stage rectal cancer, and they were treated with a drug called dostarlimab, which is another PD-1 inhibitor like pembrolizumab or nivolumab. And basically they followed 12 patients who got just dostarlimab and saw that 100% had complete clinical responses. And I'm not sure how much you can appreciate from where you're sitting, but this is examples from 2 patients showing their cancers endoscopically over time, which kind of disappeared, and also radiographically are disappearing. So that's what we mean by complete clinical response. And so this was very early data, just 12 patients, but it did make a huge splash because it was a 100% response rate, so very exciting data. This is important, particularly for rectal cancer, I would say, even more so than other early stage cancers. Rectal cancer traditionally was treated with chemoradiation followed by surgery to try to cure patients, and we were very successful at curing patients, and we are, but unfortunately leave patients with a lot of bad long-term effects. It can affect bowel and bladder function, sexual function, infertility. So these are tough treatments, and so there really is an imperative, particularly in the rectal cancer setting, to try to develop less toxic treatments that can still get patients the cure that we're striving for. My colleague Eric Christensen at Johns Hopkins has a clinical trial in kind of a similar setting, looking at a combination of PD-1 and LAG-3 inhibitor in early stage rectal cancer patients. And this is particularly focused on older patients with the idea that these patients have more risk from surgery, also more risk from the immune toxicities. So the hope here is that the PD-1 LAG-3 combination is going to be a better tolerated but still potentially curative treatment for these patients with MSI high cancers. And finally, another place where the field is going now is the interception space. This is also, referred to as prevention, and I think of particular interest to the people at this conference. We are interested in looking at whether we can use immunotherapy in patients with Lynch syndrome to prevent cancer. Obviously, the immune checkpoint inhibitors I've been talking about primarily have a lot of side effects, as I mentioned, so perhaps not the best approach for prevention, but vaccines are much more promising in this setting. They're very well tolerated, as I said, and so that's really where the focus is currently. There's a trial with that NOUS 209 vaccine that I mentioned, and another one listed here. Again, I think a very exciting way that the field is moving and a good opportunity to participate in research. So just to summarize, mismatch repair deficient cancers, which are associated with Lynch syndrome or can happen sporadically, are uniquely immunogenic. They have very high rates of durable response to the immune checkpoint inhibitors, even in the advanced treatment refractory setting. Combination immunotherapy can work better. We see higher response rates, but it can be more toxic as well. So again, we really need to try to identify better who needs those combinations and to develop less toxic combinations. I mentioned that immunotherapy is being moved into earlier stages of disease, including early stage cancer, but also prevention. And thank you so much for your attention.